us to. So let us move to the last topic, that is the newer molecules in ANCA-associated glomerulonephritis. And to talk on this, I request Dr. Arivazhagan to please, he's from Coimbatore, to please take over.
Good evening. Newer molecules in ANCA glomerulonephritis, the future. At the outset, many thanks to the ISN Southern Chapter Scientific Committee for this wonderful opportunity. So as we saw, the standard treatment for ANCA GN includes glucocorticoids, cyclophosphamide, rituximab, azathioprine, MMF, methotrexate, and plasma exchange and IVIG have doubtful roles. Basically, it can be induction treatment or maintenance treatment. Induction mainly with cyclophosphamide or rituximab along with glucocorticoids, and maintenance will be with rituximab or azathioprine, MMF or methotrexate, and we have other things for relapsing and refractory disease. So I'll start with a small case vignette. This is one of the patients we had. He's a 57-year-old male with newly diagnosed severe renal failure, creatinine 9.3 with other comorbidities. He was diagnosed to have a PR3 ANCA-mediated granulomatous polyangiitis with renal and respiratory tract involvement. He was pulsed with IV steroids, then glucocorticoids and oral cyclophosphamide. His creatinine came down from 9 to 2.5 in 1 month and it remained stable. In the initial periods, he had erratic blood sugar during high dose glucocorticoids, which was tapered down, and he was doing well for another 15 months. After 15 months, he was admitted once with heart failure symptoms, and then again he was admitted with respiratory failure, BAL, gene expert positive. It was pulmonary TB. He had ATT-related hepatitis issue, modified ATT, encephalopathy, TB meningitis, and he has a complicated further downhill course. So there is a need for newer agents at present scenario. The current standard of care has given us a good 60 to 80% remission rates, but we are also facing high relapse rates in the range of 50% over 5 years, and around 20-25% of them progress to ESRD. So we are facing a high amount of glucocorticoid-related toxicity and infections due to overall non-specific immunosuppressive agents which we are using as of now. The infections are the major cause of mortality and morbidity, the first 1 year being the most vulnerable period. Pneumonia and bacterial pneumonia being the most important infections. There's a constant search for an ideal therapeutic agent with optimal efficacy in form of higher remission rates, lower relapse rates, and minimal adverse effects. So as our understanding of ANCA vasculitis pathogenesis is evolving, we have a few therapeutic targets which can be exploited. So we have bortezomib, which targets plasma cells, obinutuzumab anti-CD20 after the rituximab, belimumab, which is an anti-BAF antibody, then abatacept anti-CD80-86 molecule, then avacopan anti-C5a receptor molecule, and vilobelimab is anti-C5a monoclonal antibody. So the list goes on like this: bortezomib, hydroxychloroquine, belimumab, abatacept, eculizumab, alemtuzumab, tocilizumab, vilobelimab, avacopan, PADI4 inhibitor, and leflunomide. The belimumab, a few words about the newer agents. It's an anti-BAF monoclonal antibody. BAF is basically a member of TNF family. It goes by other names like B lymphocyte stimulating agent and so on. It has a crucial role in B cell development. It promotes B cell survival, transition from immature to mature B cell, immunoglobulin class switching, and a subsequent antibody production. So BAF is released from a transmembrane protein into a soluble BAF into the circulation. It acts on 3 targets: B cell maturation agent, TACI, and BAF receptor. We also have another molecule called a proliferation inducing ligand, which also acts in the same receptors. And this receptor activation results in NF-kappa B MAP kinase pathway activation, resulting in induction of B cell survival genes. BAF acts more on the earlier stages of the B cell development, while APRIL acts on the later stages of B cell, that is plasma cells. The main source of this BAF is monocyte macrophage cell and activated neutrophils. The transmembrane BAF releasing soluble BAF into the circulation, and APRIL acting via 3 receptors: BAF in the earlier stages and APRIL on the later stages. So belimumab is basically a monoclonal antibody which acts against the soluble BAF. We also have other molecules which can act both on the soluble and membrane-bound BAF. The relevance of this difference is not clear yet. And we have atacicept which blocks both BAF and APRIL. So this is one study, BRIVA study, which came out in 2019. Here we had 100 odd patients in whom remission was attained with standard rituximab or cyclophosphamide based protocol, and then they were randomized into two groups. One group received the standard maintenance regimen, which was the standard then, which was azathioprine and low dose glucocorticoids, and the other group received belimumab in addition to this standard maintenance regimen. The results was belimumab addition in addition to standard maintenance means that time it was azathioprine plus steroids, did not reduce relapse. It was a negative trial. There were few limitations in this trial. Overall relapse events were very low in the whole study population to demonstrate any possible beneficial effect with belimumab. And there was a premature end to trial, as the previous speaker said. As the study was going on with the coming out of superiority of rituximab over azathioprine, the standard of care changed and there was a premature end to the trial, and the numbers achieved was very small, and the trial became underpowered. One important thing to note in this study's results was, among rituximab treated patients, there were no relapse in belimumab group, whereas 23% of them relapsed in the placebo group. This is, of course, was subgroup analysis, and it was from a very small number of patients, but this needs a look in. So this also goes with the fact that following rituximab treatment, the B lymphocyte stimulating agent, that is BAF levels, go up, and this has been demonstrated in this study and also few other preclinical studies and studies in SLE patients. So dual B cell blockade is a concept that needs further evaluation, and belimumab monotherapy without any other azathioprine or any other maintenance agent is also one area which needs a look in. So this COMBIVAS is an ongoing RCT where rituximab induction followed by belimumab for maintenance is being studied. Here we come the alternative pathway role in ANCA pathogenesis. We have eculizumab, which is basically a C5 monoclonal antibody. We have more selective agents, avacopan, which is C5a receptor blocking molecule, and IFX1 or vilobelimab, which is an anti-C5a monoclonal antibody. So C5a is an anaphylatoxin which is involved in priming, which is a key event in ANCA vasculitis pathogenesis. It is an anti-C5a receptor blocker. Clear trial was a phase 2 trial where avacopan was shown to be non-inferior to high-dose glucocorticoids along with the standard induction agents. And there was also more rapid resolution of albuminuria in the avacopan group. Advocate trial is the latest trial where avacopan was compared with glucocorticoids. It was published in February 2021 in NEJM, which led to the approval of this agent for treatment of ANCA vasculitis in October 2021. 300 odd patients were randomized into two groups to either receive oral avacopan 30 mg BD versus tapering dose of oral glucocorticoids. All of them received the standard induction agents and maintenance therapy. Avacopan was found to be non-inferior to glucocorticoids for remission at 26 weeks, and it was found to be superior to glucocorticoids for sustained remission, that is both at 26 weeks and at the end of 52 weeks. Major adverse events are significantly less in the avacopan group. One point to note here is this is different from eculizumab, which we all know, which is basically a more C5 blocker rather than C5a blocker. So the membrane attack complex is paired with this molecule, and we expect less of infections here. Beyond the glucocorticoid sparing effect, additional beneficial effects have been demonstrated in form of albuminuria reduction and GFR preservation, possibly due to amelioration of C5a mediated inflammation in the kidney tissues. Vilobelimab is an anti-C5a monoclonal antibody. It was studied in the iExchange study, which had two parts, vilobelimab plus reduced dose glucocorticoids versus standard dose glucocorticoids, and then vilobelimab monotherapy versus standard dose glucocorticoids. All received standard induction therapy and there were equal remission rates. Eculizumab were tried in only two cases because of their religious beliefs which precluded the use of standard agents. So in them they attained successful remission, but for fear of serious infections this molecule was not studied further. Bortezomib results in accumulation of misfolded proteins in the endoplasmic reticulum, committing the cell to apoptosis. Plasma cells with ongoing antibody production with all their active endoplasmic reticulum machinery are particularly sensitive to this proteasome inhibition. The long-lived plasma cells have been demonstrated to be resistant to conventional immunosuppression and B-cell depleting therapy. Plasma cells with ongoing antibody production account for a good number of refractory cases of autoimmune diseases, including SLE and ANCA vasculitis. So, bortezomib has been found beneficial in mouse model and also in few case reports of crescentic severe ANCA vasculitis. In view of bortezomib, we have better experience in refractory cases of SLE patients. But there are quite a number of serious adverse events in form of infections, polyneuropathy, skin reactions, and etc. So bortezomib, as of now, is an option, remains an option in refractory ANCA vasculitis in one-off cases. Hydroxychloroquine can be an agent as an add-on agent to standard therapy. It is well tolerated. We all have extensive experience in using this. It is an inexpensive agent. HAMN is the ongoing trial. Abatacept is a fusion molecule of human IgG1 with extracellular domain of CTLA4. It blocks T-cell activation. It was effective in relapsing GPA patients, but glomerulonephritis has been excluded in the studies with abatacept. Alemtuzumab is one another molecule which is being studied in Alleviate trial. Tocilizumab is another agent that is being studied in the satellite trial. PADI4 inhibitor assumes importance in that it reduces net formation, and it has also been found to be beneficial in animal models. Leflunomide is another agent. So to conclude, we have all these standard therapeutic agents with all landmark trials. Only one molecule among all the newer molecules which has been approved as of now is avacopan based on the results of Advocate trial in 2021. We have lots of other newer molecules for which there is some evidence in form of case reports and
Dr.
some
Arvi,
posters.
can you please conclude?
And with this I conclude my. Thank you.